Thank you. Thanks very much. And Raymond definitely did the heavy lifting here. So I'm just going to give you a little quick update on some of the work we've been doing to implement Tumor-First testing for BRCA in the diagnostic labs at UHN. And this study actually came out of a GOC meeting about a year ago, and we did it in partnership with Ali Carson and Sean Young at BC Cancer. And my conflict of interest, so this project was funded by a grant from AstraZeneca, and I have honoraria. And my objectives. So really I just want to, again, give a brief update on this study we started, talking more about the approach of tumor-first testing, as some of those questions alluded to. How can we actually start with the tumor to get BRCA germline and somatic mutations, and then show through our study how effective this could be, and then where we might consider applying this more widely in future. So as you all know then, the PARP inhibitors were approved about 2 years ago now for the patients with platinum-sensitive relapsed BRCA mutated high-grade cancers. And as Raymond mentioned, this was both germline mutations for BRCA and somatic mutations. So if you think about that, really what you need to do then is test for both the germline mutations in the blood and the somatic mutations, which will be found in the tumor, to really find the most patients eligible for the PARP treatment. And I think overall, you know, everyone's goal really is to improve diagnostic testing for BRCA as a routine and early tool for every eligible patient. So what is tumor-first testing? As Raymond sort of described, the current standard of care for inherited cancers is you'll have a referral to genetics, we go through counseling, have a blood sample taken, which then is tested for testing your genomic DNA for inherited mutations. And at least in the high-grade serous cancers, this will identify about 20% of the patients that have BRCA. Tumor-first testing really takes a different view and says all of these patients have tumor samples taken early on, so why don't we test that? We will find both the germline and the somatic mutations, so about 28% of the high-grade serous cancers. The difference here, though, is that when we test tumor, we can't distinguish those mutations that are germline from those that are somatic. So we're not revealing anything about an inherited predisposition when we test tumor. We're really just trying to capture the most mutations that we can from testing that tissue. And then from there, once you know the mutations, you can make treatment decisions. And then the next phase would be later on, either that could be done in parallel with the tumor or it could be at some subsequent time. You can then go back and test the blood to find out which of the mutations you found in tumor actually were inherited and which were somatic. But regardless, it doesn't really change the treatment decision. That's more of an issue about counseling and trying to capture all the additional family members. So benefits of tumor-first testing. Again, I think when we think about it in the lab and actually trying to implement this, tumor-first testing really does reduce the number of tests that are needed to find both somatic and germline mutations. So if you think about starting with 100 patients, how many tests are needed to get all the somatic and germline BRCA? So if you start with tumor-first, you'll test all 100. About 28 of those will actually have a mutation found that you then need to go on and test the blood. If you start with the blood, you test all 100 patients. About 20 of those are positive, so have germline, but the remaining 80 could have somatic that you then need to go back and test. So clearly there is just a straightforward practical use to start with tumor. And I think possibly even more importantly is that it might be a way to reduce the loss of patients at referrals and ease this demand on genetic counseling. Starting with tumor-first really means that only the positive patients are going to genetic counseling, to medical genetics, and trying to keep that resource for the patients that need it most. So I think again, coming to some of the GOC meetings and what we sort of talk about internally at UHN, the gaps that we sort of see, and my thinking is very much lab-based, so the gaps that I see here are, one, concordance of results from the tumor and the germline. So before the medical geneticists and counselors will be comfortable accepting results from the tumor, they want to be sure that we're going to capture all the germline mutations. So that was really what we started with. And then the other 2 points, I'll mention again later, but really we're sort of thinking ahead to what are the next steps as well. So that was really the genesis of this project. And the question is quite simple. Can we detect germline BRCA mutations reliably in tumor tissue? There are technical issues to testing formalin-fixed paraffin-embedded DNA, and as well, I'm sure you know, rare secondary reversion mutations that restore the BRCA activity. So the study was to test 100 cases of known germline inherited BRCA carriers, and we did 50 at each site, testing DNA from FFPE and using large NGS panels of the type that Raymond mentioned. So included BRCA1 and 2 and other HRD genes, and then just compared the tumor results to what was known from germline. So as of a couple weeks ago, we were done 63 cases. We're done all 50 at UHN, and Ali was about 13 in, and not maybe another month or two before he was done. So all of the BRCA mutations found in the tumor were the same as identified in germline testing in the blood. So at least in our, up to this point, we've definitely confirmed that the germline BRCA mutations can be reliably detected in the tumor. And we had mutation types across the typical spectrum for germline. The most common types, frameshift nonsense, and then the less common types. And for Raymond, we did have copy number variants, which we could detect, yes. And actually, I think that's a very interesting question. We're going to try to get more of those, too. And we didn't see any secondary reversion mutations. And perhaps that's not surprising because that seems to be an acquired resistance mechanism. These were samples from the original diagnosis or surgery. So then I think we're now starting to think about this. Really, what would it take to actually begin a tumor-first BRCA testing program? There would have to be expertise of the surgeons, oncologists seeing the patients at the beginning, maybe not so much hands-on genetic counseling, but at least supported by counselors with some kind of script. Pathologists who would then be doing reflex testing to the diagnostic labs who would have to be able to test FFPE tumor, and then the downstream parts, returning those results and what do we do with the negatives. We don't want to miss people who may have other inherited cancer syndromes. So if you're negative for BRCA, it doesn't mean that you might not be negative for something else. So we don't want to lose that group either. So just my final slide then. I think that's really, I feel like once we're done this, I really think that we will feel quite confident that we have concordance of tumor to the germline. And now, again, at UHN, we're starting to look toward this second question. So can we actually show that starting with oncology clinic-based genetic testing, it's an acceptable and efficient way to actually deliver BRCA testing? And then the second phase would be, how would we manage the BRCA negative patients? What do we do about the other genes? And just a little slide of our collaborators. Thank you very much.
That was a great talk, thank you. Quick question. In your study, you said that you tested the primary tumor. So is that the primary ovarian tumor, tubal tumor, or the omentum? Because do we know yet if before any other treatments, whether all primary and metastatic sites have the same mutations?
Right. So I think most of these were ovarian because of the way we selected them. I guess though, no matter what the tissue is that we're getting, regardless of the site, if we're looking for germline mutations, it would actually all be the same. Even if we took normal benign tissue, it would be carrying the germline mutation. We were just starting with the tumor because we're also trying to capture the somatic ones too, right? So I think that's an important question if you're trying to figure out how many somatic mutations you have. Here it was a tiny bit different. We were just trying to say, can we find the germline ones in the tumor? Yeah. But yes, that is, again, I think that's another part about implementing this. What are the right tissues? What are the ones we actually have access to? Is it sufficient to actually get DNA? So there's a lot of questions around that. And for treatment, of course. Yeah. Yes, and that's very interesting. And there's some new things coming out now, of course, with looking at circulating tumor DNA and resistance mutations within there. Yes. Hi, Stephen.
Has anyone looked at, or would it be useful to do like a cost effectiveness, comparing the two approaches, blood first, tumor first? It would seem to me that this would be more cost effective, should save the system money, because ultimately, at the end of the day, you want payers to pay for this.
Yeah,
so
of course. Yeah.
Making the argument that we're saving the money, well, it should work. It may not work to have make that argument, but
Yes.
has that been done or?
It hasn't. It's a great idea, though, and I think you're absolutely right. That really is needed to have the ministry move on the funding and how it would actually roll out for sure. I have to say that the cost is pretty easy for us to calculate in the lab because it's all very cut and dried what we spend. I guess it's more like, would we be able to calculate saved cost in genetic counseling and all of those other, right? Yeah. Yeah, that would be great. Yeah, thanks.
So you may be aware of, but through right now, LabPrib's obviously across Canada in negotiations with ministries, with the drug company trying to negotiate price. But with that, CCO had put forward to the ministry funding for primary tumor testing as the companion test, so reflexive tumor testing for all new ovarian cancers. So hopefully, if we get approval, it will be approved with the matched tumor funding. And I think that, with Aaron Pollitt as the pathology and lab medicine person, thinks there'll be centers of excellence where these tumors are sent. Probably not every site is going to be doing it. So it's great that you're getting the technology and showing due diligence that it can detect the somatic and the germline.
Great. I'm glad to hear that. Thank you.
So I understand that tumor testing is actually costly and labor-intensive as it is currently. I wonder if there's a risk of missing cases, for instance, if you're sending slicer blocks where there's not a lot of tumor, for instance, and that you may be missing cases.
Mm-hmm. Yeah, and that was partly what we were trying to show here. There definitely would be a minimum requirement for tumor that we set. So we need a certain size, a certain amount of cellularity so that we don't miss mutations, especially the somatic. Germline is in every cell. Those are pretty straightforward. But the part about the technical, it is a bit more challenging. I think the real issue with BRCA, though, is more the history, that the labs that have been running it on blood, really high quality DNA, very easy to use. And so it's kind of getting those labs to shift from that into using the more fragmented DNA we get from FFPE. So it's not a huge technical barrier, but I think it does mean resetting a bit the system that already exists, which is a bit harder.
And what about if it is performed on patients following neoadjuvant chemotherapy when sometimes they don't have a lot of tumor left?
Yes, exactly. There would be definitely a minimum amount of tumor needed. It must. I can't say that. I mean, most of the samples I anticipate we would receive would be at surgery. I mean, some may be post chemo, but hopefully most would be still of a relatively large size. But we can, for example, we can use biopsy samples. We can get quite a small amount of DNA and still have it work.